Good morning, doctors. Welcome again. Today we are going to discuss about thyroid nodules and thyroid carcinoma. The majority of thyroid nodules are benign and subclinical. The first step is to go for TSH, is thyroid stimulating hormone level, and if the thyroid stimulating hormone is normal, if TSH is normal, then go for USG guided FNSC, fine needle aspiration cytology. If TSH is normal, but if the TSH is low, then no need to go for USG and FNSE. Even I received yesterday in my OPD a patient who has low TSH, but he already gone through USG and FNSC guided biopsy as cytology for HPE. But if his TSH is low, then no mean of doing USG and FNSC. So guys, if the TSH is normal, then we need to go for this. So that patient waste his money and he comes under the classification of Bethesda 1. Bethesda. I will explain you that classification in individual topic. So I hope you understand. Now, thyroid carcinoma. Thyroid carcinoma are papillary thyroid carcinomas, most common. It's 60 to 70%. Follicular thyroid carcinoma 15%, anaplastic thyroid carcinoma 10%, medullary thyroid carcinoma 5%. And in my patient, those who go through USG guided FNSC, his TSH is low, but he visit after that because he is in another doctor hands and he advised to do such things. But if he came directly to me, if I see his thyroid level low, then I never go on USG guided FNSC because you have to follow the guidelines because nothing were there as we know according to our theory. Now radio uptake iodine, it's hyper functioning, it never be carcinoma. We give some dye orally to a patient, we give some dye to a patient, and if there is hyper functioning or hot nodule, TSS decrease, it never be carcinoma. If TSS decrease, no need to go for radio uptake iodine. But you can, if you want to confirm, then you can confirm through this dye. And if it is non-functioning, TSH normal in dye, then go for FNAC. It's cold nodule, but 10% is malignant. Okay, now how to diagnose, I will show you. If thyroid nodule we detect, we need to do TSH level as I told you earlier. Then if TSH is low, then it is subclinical hyperthyroidism. In my patient, subclinical hyperthyroidism with thyroid nodule. But guys, you know what? If this picture comes, no need to go for radio uptake iodine, or if you want, you can do, but no USG guided FNA. But if thyroid levels are normal, then go for FNA USG guided. If non-diagnostic, one more time repeat. If ATPR, repeat it. And follicular neoplasm, then second surgery lobectomy we can do. If suspicious for malignancy, then near or total thyroidectomy. Or if malignancy, then go for near or total thyroidectomy. Okay, now let's discuss thyroid carcinoma individually. Okay, thyroid cancer, PTCA. I write in such a papillary thyroid carcinoma. This is the most common type, spread lymphatically. This one is the most common type. It is spread lymphatically associated with a radiation exposure. Treatment here is near total thyroidectomy with or without adjunctive radiotherapy. The prognosis here is excellent, or we can say good. Good prognosis. Now, follicular thyroid carcinoma, elderly, we found this is in elderly. It is spread hematogenously if we do the thyroglobulin level that is high, and treatment here is near total thyroidectomy with radioiodine ablation. Why radioiodine ablation? Because there is hematogenous involvement spread, that's why we have to go through near total thyroidectomy and radioiodine ablation. Now anaplastic thyroid cancer means it's very painful, 80% mortality within 1 year. Even I saw such patient One time, a lady who's suffering from this, and she died within 3 months. And but her age is 95 years. That's why. And treatment here is palliative, means manage the pain. Pain management is there. Okay. Now, medullary thyroid carcinoma. It's sporadic or genetic, familial syndrome, or associated with man 2A and man 2B. Here there is increase in serum calcitonin and increase in serotonin. So if serotonin is increased, so there is a symptom of flush and diarrhea, and treatment here is total thyroidectomy. So guys, the history of patient is very important. TSH levels are very important. If TSH level is normal, then do FNA, fine needle aspiration cytology with ultrasonography guided. And if TSH normal are low, then it's subacute thyroiditis, hyper thyroidism subclinical. So guys, I hope you understand, and these thyroid nodules are mostly benign. So I hope you understand very well. And as I told here, that if non-functioning or cold nodule, that is 10% malignant. So guys, finally have a good day. Goodbye. I hope you like this lecture. If you have any queries, or if anybody is suffering from this, you can ask me for further treatment. Thank you. Good day and goodbye.